respected chairpersons, dear colleagues and friends, good evening to all of you. As Baiju is counting, I'm the fourth batch of from Thiruvananthapuram. Truly, this Golden Jubilee celebration or meeting is a nostalgic reunion of our days. Maybe I passed off almost more than 2 decades back, and it is a wonderful opportunity to interact. Thanks to Dr. Ramesh Rajan and the entire team for the hard work behind all this. Now, going to the topic that I have been allotted. In surgery, the difference between success and complication sometimes lies in a millimeter. And probably the classic example of this would be mucosal perforation when you do a laparoscopic cardiomyotomy. What's the incidence? If you look into literature, the published literature shows an incidence of 5 to 33%. And 2 recent studies which specifically looked into this matter, including more than 400 patients, have shown an incidence of 12.6% in one and 15.4% in the other. Now this perforation, almost 95% of situations occurs intraoperatively, and around 5% it may be probably a thermal injury which later on perforates or is detected post-operatively when you do an imaging. Now what are the implications? Now, any surgeon, while doing cardiomyotomy, if the mucosa breach occurs, raises a lot of concerns in his head. The operative time is going to be prolonged, patient's hospital stay will be delayed, he may have reoperations, delay in oral intake, post-operative leak in collections can occur, and above all, what happens to the functional outcome for the treatment for which he has approached you. From the recommendations given in literature and my limited experience in this subject, I can propose 6 tips, one by one. Optimal exposure is the key, as in all surgeries. I would prefer a French position with a steep reverse Trendelenburg tilt and the 5 ports as shown here. An Athanson's retractor is a valuable instrument when you do for all these, whether it is fundoplication or achalasia. It's a very valuable instrument which gives you very good exposure to the field. Clearly define the anatomical landmarks first. Earlier on in the surgery itself, I usually put a sling at the GE junction, which gives you an idea of where exactly the GE junction is located. It helps in the further division of the ligaments. The phrenoesophageal ligaments divided, the crura and the mediastinal dissection also becomes easier. You should tape and separate the anterior vagus nerve because it always keeps on interfering with your field when you do the myotomy. The precise myotomy technique is important. You start off above the GE junction. The longitudinal muscles are always split. When you see the circular muscle fibers beneath that, this could be either split, it could be cut with scissors, or you can do cauterization. But whatever you do, it should be slow, meticulous, and you should take your time because that's the most crucial part in preventing a mucosal injury when you do myotomy. It's important to maintain a bloodless field because if the field becomes bloody, you start trying to control the bleed and chances of mucosal perforation will definitely be more. You should always try to expose at least 50% of the circumference of the esophageal mucosa, and in around 2/3 of the myotomy that you do, more than 50% should be the aim that you should do. Only then you get adequate myotomy will be there, and preferably whenever you use cautery also, it should be in small bursts with very careful use of the cautery to avoid perforations. The ideal length of myotomy on the esophageal side would be around 5 to 7 centimeters, and on the gastric side, it is said you should do at least 2 to 2.5 centimeters, which probably is the more difficult part of the myotomy. When you have the sling in place, you know where exactly the GE junction is and the then you come across the oblique fibers besides the longitudinal and circular fibers, and it is found that in around 2/3 of cases, the perforations occur on the gastric side and 1/3 only in the esophageal side when you do myotomy. Doing an intraoperative endoscopy is definitely a useful thing, and I always see to it that in my cases I do an endoscopy. It not only detects mucosal perforations accurately, you can precisely identify the GE junction. It helps in optimizing the length of the myotomy and also set to improve post-operative outcome in studies. Now, are there any risk factors to identify which patients are at risk of mucosal perforation? Well, as the age of patient increases, the duration of disease is more, or if you've had previous balloon dilatations, or if the preoperative symptom score is high, the chances of mucosal perforation are definitely more. So also serum albumin low, meaning a poor nutritional status for the patient. When you've got a sigmoid esophagus or on the barium swallows, or a transverse diameter is large, or low ADS pressure more on manometry, the chances of perforation are more. And above all, intraoperative, most important factor would be the operative experience of the surgeon. It has been shown in studies, in the first 5 cases, the incidence of perforation are more. Well, there's no doubt, like in any other surgery, experience does count. Well, this is a study which showed the learning curve specifically for this surgery, and it is found that there is a learning curve of around 15 cases for lap Heller's myotomy. And as the number of cases increase, probably your complication and the way you're able to deal with it also will be less and better. The best surgeon is not only one who makes less mistakes, but also the one who best avoids and corrects them. Now, we all know that poem by our endoscopy colleagues is now threatening to replace laparoscopic cardiomyotomy, or the surgeon's field, and there are many randomized trials and meta-analysis which have shown equally good and some even better results. So it is imperative on our side to be able to tackle complications that we do in surgical myotomy, so that the outcome of treatment is not altered by the surgery that you do. So most of these perforations you will be able to repair, except for in rare situations where it is very large perforation or an awkward position where you are not able. Very often you'll be able to identify. It's important that you complete the myotomy properly and suture this. Usually use a 4-0 PDS or Weichel interrupted sutures, and if you are suturing it, I would prefer to keep the patient on a fasting with trials for about 5 to 7 days, do a gastrograph and contrast study on by day 5 or day 7, and only then start oral feeds. As you all know, cardiomyotomies are preferably should be clubbed with anti-reflux procedure, because studies have shown around 47% of patients show higher incidence of reflux disease if you do not club it with an anti-reflux procedure. My preference would be to do a two-pay fundoplication for all cases, except for those where if I find that the mucosa is at risk, or if I injured the mucosa and sutured it, then you need something to buttress the sutured mucosa so as to support it, where I would go for a door fundoplication. In other cases, most of the situations, I would opt for a two-pay fundoplication. Now, this probably is one relief study which gives us encouragement that when you look into patients who have had mucosal perforation during a Heller's myotomy that has been satisfactorily repaired, and manometric studies have shown that there is no significant difference in the outcome, the functional outcome of patients, if the mucosa has been properly repaired and a good cardiomyotomy has been done. So even if you're able to tackle that perforation, your results are not going to be altered by the fact that you've made a perforation. So to sum up, mucosal perforation during a lap cardiomyotomy occurs in 12 to 15% of cases, and immediate detection and resolution are crucial. Identifying risk factors for mucosal perforation and meticulous surgical techniques may decrease its incidence. It prolongs the operation time and the hospital stay, besides delay in starting oral feeds, but it does not significantly worsen the post-operative morbidity or functional outcomes, provided it is identified and repaired promptly. Thank you.